Dear colleagues, I'm Filippo, Crea editor-in-chief of the European Art Journal. Welcome to our monthly dialogue. As you know very well by now, the dialogues are Socratic conversations among journal editors, authors, and readers. The dialogues are free and live streamed, and of course, you can ask questions. Do not forget, please, to subscribe to our YouTube channel. And now it is my privilege to ask Raffaele de Caterina, executive editor of the European Art Journal, to present our guest today, Professor Murad. And the title of the dialogue today is Nitric Oxide, narrated by a Nobel laureate. Please, Raffaele, can you introduce our distinguished guest?
Thank you, Filippo. It is indeed a great honor for me to introduce Professor Ferid Murad. Ferid Murad completed his undergraduate work at DePauw University in Indiana, received his MD PhD degree from Case Western Reserve University in Cleveland, Ohio. He had medical residency at Mass General Hospital and a fellowship at the National Institute of Health. We just heard that there he met Anthony Fauci, so he's knowledgeable about the story of COVID-19 as well. He was on the faculty at the University of Virginia, Chief of Medicine at Palo Alto Veterans Hospital, Associate and then Chairman of Medicine at Stanford, Professor at Northwestern University, Chairman of the Department of Integrative Biology and Pharmacology at Texas Health Science Center at Houston, then Director of the Institute of Molecular Medicine there. From 2011 to 2016, he has been a university professor at George Washington University and Director of the Institute of Cell Signaling. And he has also been Vice President of Research and Development at Abbott Laboratories. Currently, he's back at Stanford in Palo Alto. He has been very active in both academic medicine and industry throughout his distinguished career. Founded or co-founded at least eight biotech companies, and has advised many cities and government leaders about technology development. Among his many awards and honors, Dr. Murad received the prestigious Lasker Award, the SIBA, the Baxter, the Association of American Medical Colleges Award, the American Society of Clinical Pharmacology Prize, and the President's Scholar Award from the University of Texas Houston Health Science Center. Member of the National Academy of Sciences, member of the Institute of Medicine, fellow of the American Academy of Arts and Sciences, member of many foreign academies and universities. 17 at least honorary degrees, published hundreds of manuscripts, authored or edited dozens of books. His work concentrated on the field of cell signaling and signal transduction, and in 1998, Dr. Murad received the Nobel Prize in Medicine for his work on nitric oxide. He continues research which leads to a better understanding on how information is transmitted between cells. This is just a very brief summary of his extensive CV, but gives you an idea of the great journey that Dr. Murad has done in sciences and medicine.
Well, welcome, Professor Murad, to our dialogue, and we are really thrilled to have you here. And perhaps, Raffaele, you can start with some questions, and I will continue.
First of all, I'm very flattered that I can address you like as Ferid. Ferid, your enormous scientific achievements are in the eyes of the global community, mostly linked to nitric oxide. But what was your first passion in your scientific career? How did you start being interested in vascular biology and medicine?
I knew when I was a youngster I wanted to be a doctor. I think I was 10 or 11 or 12 years old. I had a civics teacher in middle school, and she asked us to write a little term paper. What are the 3 professions you would entertain later in life? And my first choice was being a physician, a doctor. My second choice was being a teacher, because I really had some excellent teachers and I thought they really were having a good time doing it. And my third choice was being a pharmacologist, which was sort of strange. Well, this is quite a long time ago, back in the 1940s. And the reason, I was catching butterflies during the summer. I lived on Lake Michigan, Whiting, Indiana, northwest corner of Indiana, about 15 miles from Chicago. And we had marshes. I would roam around the marshes catching butterflies, and I wanted to mount them on a piece of cardboard in my bedroom. But I didn't want to pick them up and destroy their wings and their colors. So I figured out a way to kill the butterflies carefully. So I went to the local pharmacist and I said, can I have some potassium cyanide and hydrochloric acid? And he gave it to me. Today, I'd be considered a terrorist, probably. But I would catch the butterflies in my net and transfer it into the jar. And then I punched a hole in the lid of the jar, would drip in hydrochloric acid, make cyanide, kill the butterflies. And now I can pick them up and mount them without them flapping their wings and destroying all the colors. So I thought chemistry and pharmacology and drugs were interesting. So that was my third choice. And that's exactly what I do. I do all 3 of those. I trained in medicine. I do a lot of teaching at all levels, young people, senior people. And I work with pharmacology, discovering and developing drugs. When I finished college, I was going to go to medical school. And I learned about a new program in Cleveland that had just gotten started. Earl Sutherland was the chairman of the pharmacology department at Western Reserve University. And Sutherland thought that the future scientists and professors in medical schools should train both in medicine and basic science. And he created the MD PhD program. And Western Reserve was the first school in the United States to have the combined degree program, and I was one of the first students to join the program. And he had discovered cyclic AMP the year before I joined the program with Ted Rall, one of his colleagues who was working in his laboratory. And my assignment as a student, they knew that epinephrine and glucagon increased cyclic AMP in liver extracts. That's how they discovered cyclic AMP. And the question they asked, is it mediated through the alpha adrenergic receptor or the beta adrenergic receptor? Alquist was a scientist, I believe, in Georgia at the time, working with blood vessels, and decided that epinephrine interacted with both alpha receptors and beta receptors. That was the definition at that point. And Sutherland said, Murad, is the effect on cyclic AMP mediated by the alpha receptor or the beta receptor? That's your assignment as a student. Well, looking at epinephrine, norepinephrine, isoproterenol, I was able to figure out with a relative potency that it was through the beta receptor. And we also had access to the first beta blocker, dichloroisoproterenol, available in the late 1950s. And within months, I just determined that the effects of catechol to increase cyclic AMP was mediated through the beta receptor. And we then went on to look at many, many other hormones and neurotransmitters on cyclic AMP production in tissues. And that's how I became interested in cell signaling and communication. In the late 1960s, another cyclic nucleotide was discovered, cyclic GMP. A couple of chemists that gave radioactive phosphate to rabbits harvested the urine and found 2 organic phosphates in the urine, cyclic AMP and cyclic GMP. That was the first demonstration that cyclic GMP was another natural product, as was cyclic AMP. And I became very intrigued with that because I was interested in agents that would inhibit cyclic AMP production or inhibit its activity to activate phosphorylase. So this cyclic GMP I thought was going to be an agent that would antagonize cyclic AMP. And when I finished my training and fellowship at NIH, we found that cyclic GMP would inhibit the lipolytic effects of epinephrine, glucagon, and ACTH. These hormones increase lipid degradation. And if we added cyclic GMP, it antagonized the effects of the hormones. It was an inhibitor. And he did that by activating a phosphodiesterase to increase the degradation of cyclic AMP. So I was very intrigued with both cyclic AMP and cyclic GMP and thought that they were sort of counteracting each other in biological pathways. And when I left the NIH to join the faculty at Virginia, I became very, very interested in cyclic GMP. And that led to the discovery later of nitric oxide, and I can tell you that story a little bit later. But I've been in cell signaling since 1958, and it's been fun. It's taken me down a lot of paths into all sorts of biology and biochemistry and tissues, and a lot of medical problems, medical relationships have come from it. And that's what I enjoyed, is to convert the basic research into clinical application to treat various diseases. And that's permitted me to do that.
And this also illustrates the point that pharmacology may lead the pathway to great biological discoveries, because you wanted to find something that stimulated the cyclic GMP release. Is that correct?
I thought that when I joined Virginia, one of the first things I did is I began to look at plasma and urine levels of cyclic AMP and cyclic GMP. And I found that there were circadian patterns in blood and urine. There were oscillations over the course of the day. And when you see circadian patterns, it indicates to me that they're probably hormonal regulations of their production or metabolism. So I suspected that I already knew that many hormones regulate cyclic AMP. And I suspected because of the circadian pattern with cyclic GMP levels in plasma and urine, there must be hormones regulating cyclic GMP. And I wanted to find out what they were and how they did it. How were they working? I knew that hormones activating adenylate cyclase were working through their receptors to then activate adenylate cyclase. And I didn't know how hormones or which hormones were going to work with cyclic GMP. And I set out to figure that out. And fortunately, it turned out when we looked at guanylate cyclase, it turned out there are many isoforms, soluble and particulate isoforms. With adenylate cyclase, there's only one isoform, only one gene. With guanylate cyclase, there are at least 6 or 7 isoforms, a soluble isoform and 5 or 6 particulate isoforms, all encoded by different genes. So a much more complicated problem. But complexity offers a lot of advantage in terms of therapy. If you figure out the details, you can now come along with selective agents to influence biology. And that was my goal.
And what was your first reaction when you read about Furchgott description of the so-called endothelium-derived relaxing factor, which is also linked some way to my personal memories, because I remember reading that article in a library. That was a Nature article that described the divergent effect of acetylcholine on vessels with or without the endothelium. Very simple pharmacological experiments with the myograph, very, let's say, essential techniques for pharmacologists, but leading this to this unsuspected dualism of action of acetylcholine. How did you perceive that?
Well, I was at that seminar in the spring of 1980. He was invited to come to the University of Virginia to give a lecture in the pharmacology department. I met Furchgott as a student when I was working with Sutherland and Roll. I knew about his work in vascular biology. He was looking at the abundance of receptors for epinephrine and norepinephrine, and was working with alpha and beta effects, either constriction or relaxation. So I met him probably about 1962, so I knew of him. And I attended his seminar then and again at Virginia. He, with his, really a clever experiment, when he was making vascular segments, he touched the epithelial, the endothelial cells. He would remove the adventitia to get the smooth muscle segment to mount in the organ bath. And as he touched the endothelial cells, they were very fragile, he destroyed them. And one day he asked his technician, who was his assistant, to make some preparations. And he took a shortcut for some reason. Instead of making longitudinal segments, he made rings. And now acetylcholine for the first time caused relaxation. It had never caused relaxation before, even though we knew it was caused relaxation in animals and patients as a vasodilator. But this was the first time that it would relax in preparation in the laboratory with rings. And Bob is pretty clever and realized the difference between segments and rings was the presence of the endothelium. And then he did the sandwich experiment. I call it the sandwich experiment. He took two segments of vascular muscle. One contained endothelium and one didn't. And he mounted them side by side in an organ bath. And when he added acetylcholine, they both relaxed. This told him that something was coming from the endothelium to relax the smooth muscle in both preparations. And that factor was called endothelial-derived relaxing factor, EDRF. And it had a short half-life, just a few seconds. And it was blocked by agents that were blocking the effects of nitric oxide activation of guanylate cyclase, hemoglobin, and methylene blue. We'd already published that before. And after his lecture, I said, come to my office, let's talk. EDRF is a reactive species. I think it's, Bob, I think it's a free radical. It might be nitric oxide or a complex of nitric oxide. And the reason I think that is because you're blocking it with hemoglobin and methylene blue, which inhibit the effects of azide and other nitrovasodilators to relax smooth muscle. That's how it got started.
So this was published in 1980, and
right.
You at the time were working on these intercellular mediators and on the possibility of inhibiting guanylate cyclase activity, correct?
Exactly. We what we found in about 1975, we found there were multiple isoforms of guanylate cyclase. So we were doing many guanylate cyclase assays. And rather than make up the media every day, we would add sodium azide to the preparation so we can now store it in the refrigerator. Sodium azide has antibacterial properties, so we could preserve our buffers without having to make them up all the time. And accidentally, in 1975, 76, we discovered accidentally that sodium azide activated the soluble isoform of guanylate cyclase. That was the first activator that we had. We tried many hormones, they didn't work. Later, we found that hormones would activate the particulate enzymes, not the soluble isoform. And it turned out that azide would increase cyclic GMP accumulation in liver slices, heart slices, brain slices. It would increase cyclic GMP in many, many tissues and cell cultures. And one of the preparations we decided to work with was airway smooth muscle. I knew as a student it was difficult to look at messengers in blood vessels because of the heterogeneity of the cell types. You had endothelial cells, fibroblasts, smooth muscle, neuronal cells. And when you want to correlate biology and physiology with the biochemistry, it's best to work with homogeneous populations of cells. Otherwise, you're not sure what cells are making the messenger. You do know what cells are causing the physiologic response. So what I decided to do in Virginia was to work with tracheal smooth muscle rather than blood vessels. And we would dissect out the smooth muscle from bovine trachea, and now we had a very clean smooth muscle preparation. And we would mount these smooth muscle preparations in organ baths, and we added azide, and it increased cyclic GMP. And I thought cyclic GMP would cause contraction because I knew cyclic GMP relaxed, and I thought they would antagonize each other. The big surprise was azide caused relaxation. It increased cyclic G caused relaxation. I said, oh my goodness, both cyclic AMP and cyclic GMP are smooth muscle relaxants. What's going on here? And then I remembered as a resident taking care of patients with heart attacks in the intensive care unit, we would give them intravenous nitroprusside or nitroglycerin to lower blood pressure to, quote, decrease afterload so the heart wouldn't have to work so hard. It would heal faster. So I suggested to one of the fellows, let's put nitroprusside and nitroglycerin on these muscles and see what it does. It should relax. What is it going to do to cyclic GMP and cyclic AMP? When we did that, nitroglycerin and nitroprusside caused relaxation, as I expected, but they also increased cyclic GMP accumulation. That was the big surprise. I said, oh my goodness, cyclic GMP is a smooth muscle relaxant. And we now had a variety of nitrogen-containing compounds that activated soluble guanylate cyclase to cause relaxation of muscle. And we call these nitrovasodilators. We coined the term of all these nitrogen-containing compounds. They were nitroglycerin, azide, hydroxylamine, sodium nitrite, nitroprusside, inorganic and organic nitrates and nitrites. They were all, donors. And we said, what are they being? They're being converted to something. What is it? They all can't be working on the same receptor or same mechanism. They have to be converted to some activator. And it took us 2 or 3 years to figure out what that activator was. And we finally realized because hemoglobin would block the effects, we said, my goodness, maybe it's nitric oxide. And I knew that nitric oxide had a high affinity for hemoglobin from my chemistry classes. So sure enough, we generated nitric oxide in the fume hood in December of 1976. We took sodium nitrite, hydrochloric acid, and ferrous sulfate, mixed them in the fume hood, vented the gas into our guanylate cyclase incubations, and activated all the soluble guanylate cyclase preparations to be tested. That was the Eureka moment. We found nitric oxide, a free radical, a gas, would activate an enzyme, and that was exciting. That's it storied. That was 1976, 77. So it took off. It became really interesting. How could a gas and free radical do something so unusual as to regulate and activate an enzyme? It was unheard of.
And did you know the third actor in the field, Luis Iñarro, at that time?
Yes, I did.
Did you know him already?
Yes. We, back in the 70s, we would have every 2 years or so cyclic nucleotide conferences somewhere. And in 1972, Iñarro and one of his colleagues co-chaired the meeting in New Orleans. So that's where I first met Lou Iñarro, in New Orleans at that meeting. He was co-chair of the meeting. So we became friends and colleagues for a long time. At that point, he was working with cyclic CMP. He thought there was another cyclic nucleotide. Well, it turned out that those data were not correct. He was not purifying his samples properly and for his assay. So at some point, he retracted all that data. But that's when we first met in 1972. But after our discovery of nitroglycerin effects on cyclic GMP and smooth muscle relaxation, he got very interested in vascular biology and cyclic GMP. That's how he got started. And his experiments were about 4 or 5 years after our experiments were starting. But anyway, I convinced Furchgott that we should collaborate. That collaboration didn't happen, unfortunately. We then moved from Virginia to Stanford, and we had a scientist from Virginia came to visit Syntex, which is across the street from the VA hospital where my laboratory was, Mike Peach. And Mike was interested in vasculobiology and prostaglandins and calcium. And he asked us what we were doing with EDRF. And I said, we're waiting for samples from Furchgott. And let me find out if he ever sent any. So I called the fellow in the laboratory to come into my office and meet with Mike Peach. I said, have you ever received samples from Furchgott? And he said, no. But then he smiled. And I said, what's going on, Robert? He said, I've done the experiment and the samples are frozen in the Revco. I said, Robert, tonight you're going to ask me them. Tomorrow you're going to tell me if it works. Does EDRF increase cyclic GMP? And the following morning, we discovered, yes, it does. And EDRF was probably nitric oxide. It was working through cyclic GMP. That was discovered in 81, 82, somewhere around there.
Yes, so this is a story that happened between 1975 and 1982. Right. And at that time, did you have the sensation that this would be really a breathtaking discovery that leading to the Nobel Prize?
I thought it was very important. You know, nitroglycerin was made by the Italian chemists actually in about 1847. And when chemists make compounds, they often lick their finger and stick it in the powder and taste it. Why they do that, I'm not sure. But that's for the chemists, that's very common. And when they did that, they got vascular headaches. And the European physicians realized that nitroglycerin, besides being explosive, was a vasodilator. And they began to use it in the 1870s and 80s in patients with angina and with heart attacks. And it had been used for 100 years to treat heart attacks and angina, not knowing the mechanism of action. And we discovered it was a prodrug or a precursor that was converted to nitric oxide. That was rather exciting. So I knew it had clinical relevance because of the nitroglycerin relationship. And the question is, where is it going? A free radical and gas activated enzyme was a new interesting concept. I felt that needed some more work. I knew it was important, but I didn't know how important. It took a couple more years of work. But then at some point, other people began working with it, and it became obvious it was going to have lots of other biological effects in the field. Probably in the mid-1980s really took off. The first real clinical application was treating premature babies with pulmonary hypertension and shunting right to left through the patent foramen. If they inhale low doses of nitric oxide, dilate their blood. In utero, the baby gets oxygen from the mother's blood in the placenta. Its lungs are poorly developed. So if the baby is 1 or 2 kilos at birth, it doesn't have good perfusion of the blood vessels in the lung. It shunts blood right to left through the patent foramen in the atria and also the patent ductus. So they're hypoxic blue babies. And Warren Zappo realized that nitric oxide, because of our work with blood vessels, might influence vascular delivery of oxygen in premature babies. It tested it, gave babies low doses of nitric oxide, and sure enough, it worked. And that was back in the early 1990s, so about 92, 93, 94. There was a conference at NIH, I think in 92 or 3 that I attended, where about a dozen doctors were there, pediatricians, who were beginning to use inhaled nitric oxide for premature babies. And that was exciting to see. That was the first clinical application. Now there are many others, but that really got all of us very interested. It was doing something important.
Well, Ferid, it is really a great emotion speaking to a Nobel laureate who changed the history of cardiovascular medicine, and your story starting with butterflies and ending up with nitric oxide is really fascinating. But now I have a personal question. How did you celebrate the Nobel Prize? Do you remember?
I have a big family. I have 5 children. They're all married. They have children. I have two brothers. My wife has three sisters. And we took everybody to Stockholm. We took 51 people to Stockholm. And we had a great time. We were there for about 9 days. It was really a wonderful trip.
Where were you at the time? Where were you at that time?
I was at the University of Texas at the time.
Texas, yes.
In Houston.
Now, I think we have a question from the audience, from Dr. Wang from London. Dr. Wang, could you please ask your question?
Hi, can everyone hear me okay?
Yes.
Hi, Professor Murad. Thank you for allowing me to on this panel. I am a postdoc fellow in the Division of Virology at the Crea Institute in London with an interest in nitric oxide in the immune system. I understand you have been supporting some important initiatives around.
Ming, sorry, it's not so clear. Could you speak it more loud?
Yes, your microphone is probably.
More slowly, please.
Hello. Is that okay now?
It's better.
Better.
Okay. Yeah. All right. Sorry. I'll start over.
Yes, please.
So, I'm a postdoc fellow in the Division of Virology at the Crea Institute in London with an interest in nitric oxide and the immune system. And I understand that you have been supporting some important initiatives around nitric oxide therapies to reduce the spread of the SARS-CoV-2 COVID-19 pandemic. And hear that trials of the Sanitize, which is a company, nasal spray have gone well in Canada with Dr. Stephen Winchester in the UK. It seems apparent that the SARS-CoV-2 virus favors hosts who are dysfunctional in nitric oxide production already, including those with metabolic syndrome and hypertension and with chronic inflammation such as the elderly. Do you believe that low nitric oxide levels in these vulnerable groups are the reason why they are so predisposed to the virus, and what might this mean for global health and for their treatment?
Thank you, Ming.
Okay, let me try to answer this. Carl Nathan was the chairman of infectious diseases, I think, at Cornell University in New York. Found, and Carl's interested in fungal infections, tuberculosis, a variety of things, and he found that nitric oxide was cytotoxic with a variety of microorganisms. Bacteria, fungus infections. I think he even worked with some viruses, as I recall. I was asked to be on the board of advisors for Sanitize, a company located in Vancouver, Canada. And they developed a topical nasal spray for sinusitis and a topical to treat fungal infections of the foot. The fungus can attack some of the toenails sometimes, the fungus infection. And they found that topical preparations that delivered nitric oxide, and usually these are sodium nitrite plus a weak acid with a pK between 4 and 5, you'll generate nitric oxide, that they were killing the organisms. And that really came from Carl's earlier work with the donors. And they asked me to be on their board, and I was asked to go to a meeting in Jerusalem, actually, for the company. There's a venture capital company in Jerusalem, which is the largest venture capital company in Israel, actually, that was giving them support. And they were having their annual meeting, and they asked me to come along and if I wouldn't talk about nitric oxide from a different perspective. And at that meeting, I had learned that there had just been a study from a laboratory looking at nitric oxide delivery to pigs to kill the coronavirus. And I suggested to Gilly Regev, who is the president of the company Sanitize, she and I were there together talking about nitric oxide. I suggested that she should do some studies with coronavirus to see if nitric oxide wouldn't kill it, and I suspected that it would. They then contracted with a company in Utah, a commercial company that tests various antiviral agents, and indeed found that nitric oxide was cytotoxic. It killed the virus in seconds, less than a minute. And they were testing it on a variety of viruses, including the coronavirus, the COVID-19 virus. So that then led to some clinical trials, and they then initiated clinical trials in Canada, the UK, Israel. They're now doing some other trials, I think in Singapore and Southeast Asia. And I've been an advisor with these studies. So I'm very much aware that, is cytotoxic. It'll kill almost everything. It's a free radical. It can oxidize lots of things and cause reactions. But you got to use the right amount. It can be toxic if you use too much. So what they're doing is delivering it topically with a nasal spray for the coronavirus. And it is preventing infection, and they suspect that it will also reverse the infection, perhaps. They don't have data yet for therapy. It's more prevention because the virus enters through the nasal airways to attack the A2 receptor in the pulmonary airways. So it is effective. There's another company that has taken nitrogen in the atmosphere, and they run it through an electronic device and convert it to nitric oxide to make plasma, And they've been delivering it to diabetic ulcers, and it cures diabetic ulcers. It's antibacterial. It's also a vasodilator, so it improves healing of the diabetic ulcers. It looks and that's a nasty disease. Many patients lose their limbs with the horrible diabetic ulcers, and it's been very promising. They are now thinking about developing a device to inhale the plasma NO, and so they're considering coronavirus therapy as well. And I believe they're doing some studies in China. I'm not sure. So yes, it's got application in a variety of infections, including coronavirus.
Ferid, out of the many, many branches that were started from your discoveries, what do you think have been the most relevant in terms of translation into practical applications?
Well, I think that the cardiovascular has been the most obvious with pulmonary hypertension and shunting in premature babies. There are some studies with heart failure, actually, taking another approach. Bayer, I believe, about a year ago, came out with a product that's a guanylate cyclase activator. It'll activate by a different mechanism than nitric oxide does. Nitric oxide binds to the heme prosthetic group to change the activity of the enzyme and activate a couple hundredfold. They have another compound approach that will activate the enzyme, and they've been using it in congestive heart failure. And it looks very promising in heart failure, which is great because we really don't have very much to offer patients with congestive heart failure. It's the only thing we've ever really had was digitalis, and the problem is that's got a narrow therapeutic index because of arrhythmias and other problems. It's not as popular as it used to be. So we really do need some drugs for cardiovascular heart failure. I think they're coming now. So most of the applications are cardiovascular related. They're going to be antibacterial, antiviral related as well. But there are also other we know that it plays a role in angiogenesis. It turns out that if you treat stem cells with nitric oxide or cyclic GMP, you can influence their proliferation and differentiation. We know that cancer has an abnormal soluble guanylate cyclase. It lacks the alpha subunit. So you can't activate, but with, the soluble guanylate cyclase in cancers is not activatable by nitric oxide because it lacks the alpha subunit. Beta migrates into the nucleus and somehow regulates transcription. And we think that nitric oxide can have effects on angiogenesis. The tumor is making a lot of NO. It has a lot of NOS too, the inducible NOS, to make NO. Why is it making NO if it doesn't have a normal cyclase? We know cyclic GMP is a tumor suppressor. If it made cyclic GMP, it would kill itself. So it doesn't do that. Instead, it's making NO to promote angiogenesis to feed the tumor so the tumor can grow. So there's a relationship between the angiogenesis and tumor proliferation and differentiation. I think that's going to be another area of therapy down the road. We're not there yet. We've got to figure out what the molecular target is for cyclic GMP in transcription.
So we see that you are so much enthusiastic about this prosecution of this continuation of these research lines that really it is for us very inspiring, the fact that one loves his work with so much passion and continues to follow. What will be your next challenges, Ferid, at this point?
I'd really like to come up with some novel therapy for cancer.
Great thing.
Anything you can anticipate?
Well, I need to, we've been working on this cancer problem for about 20 years. It's not an easy problem. I'm not a molecular biologist, really. I wish I had training in molecular biology. The genomic complex has just had so many factors that bind to that complex. You don't know which are participating in helping. We know that if we take cancer cells and extract the nuclear material and we immunoprecipitate the beta subunit with antibody, that is, we can pull down the beta subunit and it comes down with a genomic complex of other proteins. It comes down with polymerase II. It comes down with other things, but there are too many things. I don't know which is the target for cyclic G or NO. We've got to know that specific target. And if we know the target, then we can develop an agent, a ligand that binds to it to influence cancer. That's my goal.
Wonderful.
I'm not sure I'll live long enough to figure it out, though.
You will, I'm sure.
Ferid, you are born American, but you are second generation American with a European ancestry. Can you tell us more about your remote roots and how do you feel connected with that?
One of my daughters was not able to have children. And they've been trying and not successful. And she went through in vitro fertilization and it didn't work. And she went back a second time because when they do in vitro fertilization, they take extra eggs and freeze them and store them. But they weren't stored properly. So the issue was, does she repeat the in vitro fertilization again, or does she then adopt a child? And I told her, would you like to adopt a baby, Marianne? I said, your mother and I travel all over the world. We can find a baby for you. And she went home and thought about it for a couple of weeks and came back and said, yes, I'd like to have a baby. Well, shortly after that discussion, I was visiting Macedonia and had a nice relationship with the president of Macedonia. He had become a friend, actually. I'd been there several times. I said, can you help me get a baby? And he said, we'd love to get a baby for the Murad family. So my daughter was able to adopt an Albanian baby. So we have roots now through this child. This girl is now, let me think how old she is. She's probably in the mid-20s, 25 or 26 now. And we adopted her, she was only 3 months old. So Macedonia pulls me back frequently. Albania, it does as well. I've been to Kosovo several times. So we have a lot of friends there and some previous relatives. When I visited, the president of Albania wanted to give me an award. And I was really pretty busy at the time. And I said, I don't have the time to come. But then the next year I was invited to go to Tunisia for a lecture. And I said, I contacted the president of Albania. I said, we're going to be in Tunisia. It's a short hop to come to Albania. We'll come through Italy to Albania. And he invited me to come. So at that point, we were able to develop relationships and get the adoption started for the child for that trip. So we've gotten to know many people in the Balkan countries.
Well, thank you, Ferid.
On that trip, I wanted to visit my father's village, a very small village, Vista. But it was very difficult to go between Albania and Macedonia. The only way to get to Macedonia was to go to Vienna and then back to Skopje. You couldn't go from Italy to Macedonia. So we did go from Italy to Tirana, Albania. And at dinner that night with the president, I said, can I borrow your helicopter? I need to go to Macedonia. Can you take me to the border with your helicopter? And he provided us a helicopter for a couple of days to go back and forth. And when we got there, the mayor of Gostovar made me an honorary citizen. And we then visited Vista, this little village close to Gostovar. And I discovered that we had about 25 relatives in Gostovar, still there. Lots of family. So.
Thank you, Ferid, for sharing with us your life. Now, medicine. You have been very active in academic medicine and industry. What are, you think, the strengths and limitations on the two sides? Industry and academic medicine.
Well, they're very different. I've always had a rather large laboratory. Certainly in the last 20 or 30 years, I've typically had 15, 20, 25 people in my laboratory. They're very successful getting grants and fellowships and whatever. At Abbott, as vice president of research, I was in charge of both pharmaceutical basic research and clinical research. I had 1,500 scientists. We could do an awful lot of work that wasn't possible in academics with the resources, the staff, the implementation. But it's very, very different. As an academic, you're successful if you get grants and you recruit talented people to come work with you. And you get a lot of recognition for your successes. And it's individual recognition, or a small team. It's not the company. In a company, it's the big group getting recognition because you're creating a product that's very successful for the whole company. So it's a different type of recognition. It's not individual recognition in the company, it's team effort. Whereas in academics, it's more the individual or a small team. So, but what you can do in different environments, you can do it a lot more in industry because of all the resources and all the people, lots of, my research budget, the first couple of years at Abbott was over several $100 million a year. That's a lot of money.
And difficult to get it in academic medicine, although.
And in 5 years, I discovered about 24 new drugs. That was exciting.
At the time you were directing the Abbott laboratories, you could keep your feet also in the academics at the same time?
Yes, I had an appointment at Northwestern. I was giving lectures. in the pharmacology department. I had a laboratory with about 20 people. We had NIH grants, NIH fellowships. One of my fellows had a DFG award from Germany for his salary. So we had a big productive laboratory. I was busy between my laboratory and my job. I like to be busy. I'm always busy.
So the best of two worlds.
Ferid, our first dialogue was with Jean Brownwald, who is the legend of cardiology. Do you know each other?
I went to the NIH for a fellowship in 1967. I was there for 3 years. I was there as a senior clinical research fellow. Brownwald was head of the cardiology division in the Heart Institute when I was there. And Don Fredrickson was the clinical director of the Heart Institute. Fredrickson got promoted to be the director of the Heart Institute. Brownwald was then promoted to become the clinical director. And with the clinical director, we met with Brownwald every week to discuss the patients on the ward, the cardiology patients and the endocrine. The patients in the Heart Institute were primarily endocrinology, metabolism, or cardiology. So yes, I got to know Brownwald quite well at weekly meetings.
Really a small world. Ferid, I have one final question. I ask all our guests. What are your suggestions for the future of our dialogues?
Well, I thought about this. I think I know Brown and Goldstein quite well. They were my interns when I was a resident at Mass General. I would suggest that you contact them and get them to participate. You know, their work with lipids is very relevant to, obviously, cardiology. And I think they would do it. They are really talented young people. To work with them was exciting. They're really smart boys.
Thank you, Ferid. And this concludes our dialogue. Really, I wish to thank you for sharing with us your time. Thank you, Raffaele, for your participation. It's been really a fascinating hour. A pleasure to discuss with a Nobel laureate these important discoveries. Thank you, Ferid. It's been really very kind of you to share your time with us. And it's also my pleasure to announce our next dialogue, which will be in 2 weeks' time, according to our usual schedule, the last Thursday of the month. So next dialogue will be on June 24th at 17 CET. I hope to meet all of you in that occasion. But before leaving Ferid, any last remark, any last comment for our audience?
Any suggestion for young people?
I've been very fortunate to have worked with a lot of talented people, obviously. Very, very influenced. With all my moves, I've worked with really fantastic people. You know, talented clinicians, talented biochemists, pharmacologists. And that's exciting. And you sort of walk away after all this training, and I've had a lot of training, being influenced by all those people who I met. I mean, I really met some of the most incredible teachers at Mass General, really wonderful clinical doctors and teachers, but really great scientists along the way as well in the laboratory. I've been lucky.
Well, thank you for sharing with us your time and your experience. Let's wait for your next Nobel Prize, because you are so active that it would be no surprise to have a second Nobel Prize. Thank you again, and I wish all the colleagues joining us for this pleasant hour. Bye-bye, everybody. Bye-bye.
Bye-bye.